Erin and I want to start with a really big, heartfelt first bite thank you. We have been so encouraged by your kind word, your messages, your glowing reviews of First Bite. This has been a labor of love for the last year and a half, and we are grateful for y'all being on the First Bite journey with us and supporting us because we work full time and this is a full-time gig on top of it. And we do it with joy because we understand that the world of early intervention pediatrics needs evidence in it. So we sweet talked the folks with speechtherapypd.com, and as a thank you giveaway, we have come up with a free pod course subscription. So once we hit 130 iTunes written reviews, we're going to pull another name out of the hat, probably with the assistance of an ever so handsome goose and a bear. And that person will get a free pod course subscription. So over 175 hours of continuing ed plus 19 new continuing hours each month. And there's a new episode every Monday, Tuesday, Wednesday, every other Thursday, and the short course, 9 series long, All Things Ethics with Elise. And that's our way of giving back. So thank you. So please keep the reviews coming. We only have a few more to go, but once we hit 130, then we will pull that name out of a hat. Happy 2020. Thank you for joining us on the journey. And seriously, y'all rock. Thank you. Hey, so by now, I'm hoping that you've heard about the brand new pod course subscription that Speech Therapy PD has rolled out. For $79 a month, you get over 175 hours of ASHA continuing education with 19 new episodes a month. That's fantastic. Well, they want to make sure that you also know we have a brand new coupon code. So the coupon code is F as in first, B as in bite, followed by the number 20, FB20. And that brand new coupon code will give you $20 off the pod course subscription. So you get 175 hours of continuing ed plus an average of 19 new hours a month, all for $59 a year. And we cover everything from early intervention to schools to adults to ethics. So be sure to type in F as in first, B as in bite, and then the number's 20. Enjoy your coupon, or as my kin folks say, enjoy that coupon. Hi folks, and welcome to First Bite, Fed, Fun, and Functional, a speech therapy podcast sponsored by speechtherapypd.com. I am your host on this nerd venture, Michelle Dawson, MS, CCC-SLP, CLC, the All Things Peds SLP. I am a colleague in the trenches of home health early intervention right there with you. I run my own private practice, Heartwood Speech Therapy, here in Coletown, South Carolina, and I guest lecture nationwide on best practices for early intervention for the medically complex and fragile child. First Bite's mission is short and sweet, to bring light, hope, knowledge, and joy to the pediatric clinician, parent, or advocate.
By way of a nerdy conversation, so there's plenty of laughter too.
In this podcast, we cover everything from AAC to breastfeeding,
ethics on how to run a private practice,
pediatric dysphagia to clinical supervision,
and all other topics in the world of pediatric speech pathology. Our goal is to bring evidence-based practice straight to you by interviewing subject matter experts.
To break down the communication barriers so that we can access the knowledge of their fields.
Or, as a close friend says, to build the bridge.
By bringing other professionals and experts in our field together, we hope to spark advocacy, joy, and passion for continuing to grow and advance care for our little ones.
Every fourth episode, I join in. I'm Erin Forward, MSP, CCC-SLP, the Yankee by way of Rochester, New York transplant who actually inspired this journey. I bring a different perspective, that of a newish clinician with experience in early intervention, pediatric acute care, and nonprofit pediatric outpatient settings.
So sit back, relax, and watch out for all our squirrels and enjoy this geeky gig brought to you by SpeechTherapyPD.com. So today's guest and today's episode fall in the fun and functional categories because we have the perfect guests for our very special Cinco de Mayo episode. It's the one and only Vince Clark from Georgia, y'all. Now, this sweet man is a swallowing expert, and he can pass a scope like it's nobody's business. So if you're about to partake in a few tacos this evening and you're worried about getting one stuck, well, Vince is your guy. So like all of our guests, everybody that comes on First Bite, I like to give you the backstory. And this is my backstory with Vince. A few years ago, when I was just starting out, I was very much a fish out of water. And I was asked to go to Georgia for their state convention to do a presentation. And it was my first real public speaking gig, so to say. And I was a nervous wreck. I had talked a few times in South Carolina, but I was so far out of my turf and panicked. I mean, down to which kind of tights do I wear? Do my shoes match? Like all of the details, right? But I went and I showed up in Athens, Georgia. And plus that I really need to look at a map more frequently because I did not have a freaking clue that it was home to the Bulldogs or a college town. But I figured it out really quick when I was surrounded by Bulldog baseball players and a bunch of fabulous Georgia SLPs. And we were all crammed in the elevator because I guess it was a home game and the convention. And I must have really looked like a deer in headlights because I turned the corner completely lost in the exhibit hall. And y'all, if you haven't been, the Georgia Speech Hearing Association, they have all the poster presentations. So there I was lost between the posters and I heard this booming Georgia drawl and a laugh that made my bones feel like they were at home. And there was Vince. And he took me under his wing and he made sure that my entire stay was joyful. So, Vince, first, thank you. But flash forward a few years and our paths kept happily crossing as the world of dysphagia for all ages is small. And we've had the pleasure of having him come to Skisha a few times. The last time that you came, all the students were trying to pull strings with the board members. They're like, hey, you were my professor, or hey, you were my supervisor, because they all wanted to be picked to have Vince scope them during his live lecture. And you love what you do, or you love being in grad school to do this when you volunteer for a hose in your nose in public. So on that lovely awkward note, Vince, thank you for coming on. And how in the world did you get into this crazy subsection of speech therapy?
Well, thanks, Michelle. And it's my pleasure to be here. I tell people when they ask about how did I get involved with swallowing and swallowing disorders, I remember sitting in a classroom in, I believe it was 1997. And at that time, there was not a dedicated class for dysphagia like there is now, or multiple classes for dysphagia like is commonplace. Dysphagia was a part at Valdosta State University of motor speech disorders. And it was probably about 3 days worth of lecture.
That's it?
That was it. And that was very commonplace during the time, if you got anything at all. And most people were told, if you work with swallowing disorders, you'll learn that once you get out of school. You'll learn that in whatever your clinical setting may be. But I remember sitting in class and it really speaking to me more than anything else ever had in undergrad or graduate school. And it was fascinating to me that we as a profession had the capacity to diagnose and treat. So I really didn't know what that meant at the time. We talked about thickening liquids. We talked about chin tucking and all this good stuff. And, we were told that, you can do this test called a modified barium swallow study. We didn't even hear anything related to fees or endoscopy for swallowing. And it kind of stuck with me. And I knew that I wanted to be in a setting where I could work with people with swallowing disorders. So out of school, that led me to a skilled nursing environment. And I did some PRN work at local hospitals. But what I figured out within the first 5 years of being out of school was that, maybe the people that I was learning dysphagia from weren't necessarily the most astute at teaching aphasia. So I decided that I really wanted to deep dive into that area and kind of specialize. That's what I wanted to specialize in. So I started paying for my own CEU courses, getting anything that I could, associating myself with people like Lori Burkhead, Dr. Lori Burkhead, people that could mentor me and really teach me about what it meant to be a good dysphagia therapist.
You just hit the nail on the head. I get a lot of people reaching out asking, well, how do I actually learn about pediatric dysphagia? Because that's kind of where the state of the peds dysphagia world is right now. Some more progressive universities have a semester-long peds dysphagia class. Some now split their dysphagia class in half, so it's half dysphagia, half peds dysphagia. But all they can do is scratch the surface. So if you really, really want to get into it, you're gonna have to, unfortunately, and y'all, I am still there. I want to get certified in the BCSS licensure, but I need to take additional coursework before I'm there. And then I want to do NDT training for tiny humans. And you have to be able to dedicate the time and energy and finances to it. So yay you. Yeah. And it's not like we make the money to afford to do this, by the way, just saying.
Well, I have to say I had a great job for 21 years, I worked with Community Health Systems of Georgia. So anybody that may be hearing this that's from Georgia, they would know that organization as Ethica Health and Rehabilitation and Integra Rehab. And they were actually very supportive of CEUs. Community Health Systems of Georgia is a not-for-profit organization. So we did actually get a stipend all those years to, go to CEUs and to learn and expand and to kind of, be more progressive than some other SNF, skilled nursing facility organizations probably were, that were more money-driven, that were more for-profit. So, yeah.
They have a beautiful website, by the way.
Mm-hmm. Yes, they do.
I'm on it right now.
Yeah, and some beautiful buildings. They very much the people that I had the pleasure of working with for all those years were very progressive, forward thinking. They were looking at building facilities and remodeling buildings where people felt like they were at home, where they felt like they were at a luxury hotel for rehab. And so, the impetus was that, we would be in an environment where we were competing for the best patients. And so in order to appeal to the best patients, you've got to have a reason for them to come to your facility over someone that you're competing with in the area. So yeah, I had a great learning experience, and and I know this talk is specifically, that we were going to discuss fees. It was in 2010, 2011. I went to my then boss, that is also my good friend, Wendy, on Angel. She's also an SLP, vice president of rehab services. And I said, we really need to start looking at fees. It is the future. It is what we're going to be doing more and more and more of. And as we have progressed and had more research in swallowing, we now know that a lot of what we're doing at bedside just doesn't hold up when you put it under the scrutiny of research. So I said we need to be moving in that direction. And so around 2012, well, actually, I had been trained in going back in time a little bit. In 2009, I'd attended, Emory has a annual course, but it's more of a general nasoendoscopy course where where you learn how to do passes, where you see equipment, where you're kind of exposed to both fees and stroboscopy. 2011, 2012 is when I went to a course sponsored at the time by EndoHD, Altera Vision, and taught by Dr. Michael Crary, where it was a total, 3 days deep dive into just fees, just scoping for swallowing. And, once it's it's kind of like I tell people that being fees trained, being modified trained, it's kind of like the Matrix. Once you take either the red or blue pill, you see reality as it really is, and you either choose to ignore that world or you are viewing reality as it should be. And
no, I was going to say that's a nice way of saying either you get on board with an instrumental exam, fees are modified, or you continue to think that you personally have X-ray vision and can see through.
You continue to live in I call it continuing to live in a world of cognitive dissonance, where you tell yourself that you can do things, that you can't really do.
I'm pretty sure my 5-year-old lives in that on a daily basis.
And that's okay for 5-year-olds, but probably not adult clinicians that are, hold people's hands in their lives. Yeah.
Yes. God bless. Oh, my stars. Okay, y'all. Vince and I were chit-chat before we kind of got started. And the whole premise of this, and I know we're doing much better as a profession. And I remember when I was coming through grad school and I was getting trained, I was taught cervical osculation. I don't even think I can say the word right now.
That was close. Auscultation.
Yes, there it is. See, this is why I teach people to swallow. It's because I'm not the Arctic phonology therapy.
Right.
And I was taught by a lovely clinician that because our rural country hospital did not have the capacity to do instrumental swallow exams, fees, or modified, that we didn't need it, that we were fine. We could do cervical, Vince has got the word, and listen through a stethoscope and tell whether or not a person was aspirating by a series of clicks and pops. I'm pretty confident that because of that, that's why I'm a hypochondriac when I'm laying at night and I can feel the own clicking and popping in my throat. But no, that's just arthritis in my body. But no, y'all, we can't. And there is science and there's literature out there. And yes, Vince's background is adults, but what's good for the goose is good for the gander. And we've got to understand the basic principles of fees and why it's of merit and why we need to advocate for it for our little ones, especially in our world for the infants that are breastfed. So, okay. So you kind of gave us some backstory on how you got started with fees, but was that pretty cutting edge when you kind of rolled in 2011 with it? That's...
So what was cutting edge about it? You did have people like Stu Bradley with Carolina Speech Pathology that had been providing contract services for fees for probably over a decade. So there were people out there, going into skilled nursing, doing fees as an option. Was it cutting edge? Yeah, because a lot of people didn't know about it necessarily. And what was different about what we were trying to do was we were trying to take it internally. We were trying to do it within our system, which consisted of 90 buildings in the state of Georgia. So we were servicing 90 plus buildings. Yeah, so we were servicing from Dalton, Georgia, which is up near Tennessee, all the way down to we had buildings along the close to the Florida border, all the way over to Alabama, and then all the way over to St. Simon's Island. So we were trying to cover the whole state of Georgia, and what we were able to show was that when we were using fees and when we had kind of what I call carte blanche access to it, like if a therapist had a patient and needed a study, they didn't have to jump through a bunch of hoops to get approval. They could just pick the phone up and give us a call, and we would show up to do the study. What we were able to show was that doing that instrumentation actually saved the facilities money. We were able to, get people off of altered diets and thickened liquids. And we were able to have rational conversations with nurse practitioners, physicians assistants, MDs. It just elevated the level of respect that they had for us in their eyes. And I tell, when I teach classes, when I go out and do CEUs all the time now, one of the questions I get all the time is, or comments that I get is, I feel like the physicians and other advanced practitioners that I'm talking to don't respect me. And I don't really try to make them feel better about that, because my response is they probably don't, because you can never give them a concrete answer about what it is you're doing with their patient. When they give you a referral, when they say, I want you to go to room, whatever it may be, and do a swallow and eval, and you come back and ask them more questions than you provide them answers, of course they don't respect you. When you can come back and say, I did a modified or I did a fees, and this is what's wrong, then they're going to be on board.
And that is true for those of us that work in the home health and outpatient clinic setting. We don't have access to these instrumental exams. So, y'all, this is where, to quote my sweet friend Leslie, this is where we have to build a bridge with the individual that does the instrumental exam. Okay. And one, because this was a hard growth for me as a business owner. The prior home health companies that I worked for did not send their eval 90-day plan of cares or discharge notes to a physician. So because of that, the physicians were honest to God flying blind as to what it was that we were doing in the world of home health. This run rampant in EI events. It's like one of the bane of my existence. And so, that was a big switch. I started making sure that my eval, my 90-day plan of care, and my discharge summary got there when I was treating a patient. And that improved the flow of communication. It also made it easier when I picked up the phone to say, hey, I'm seeing a change in baseline status, for better, for worse, whatever it is. I think we need an instrumental exam. They were quicker to make the referrals because they had baseline continuity of care, which when you're in home health, when you're in an outpatient clinic, that's hard to obtain, especially when the physician's not right down the hall or around the corner in a cubicle. But then you also have to make sure that you somehow build communication with the facility that you are sending that patient to, because from me to you, I need that person doing the diagnostics to know what it is that we are observing that has raised suspicion, or what changes happen. Hey, we started Onvi for seizure management, and that can cause a whole host of issues, or hey, they're tapering down off of a different seizure medication, Keppra. They're coming down off of Keppra. And we're having, like, for lack of a better phrase, awakenings. And we're noticing that they're increased sign symptoms for hunger, and they're wanting more. And, are we cleared to do more than 5 mLs trials and those kind of factors? So,
Right.
sorry. Continue. I'm sorry. Yeah.
No, you're, I mean, you've got it. And, I tell people all the time, it is hard. I get that we all don't have access, as we should. But I think the positive thing about it is, and one of the reason, that I'm such a fan of fees. Fees is something that, is in theory portable. We can bring it into any location, which to me means that, there's room to start using this stuff in the home for, like, pediatric home health, in a clinic for pediatric home health, to try to coordinate visits so that, maybe you can do it in a doctor's office if that's what you need to do for, more fragile kids or whatever. But there's just this wide open world there that I think, I hear more and more and more about people being interested in providing fees for pediatrics. And I think that if, our payer sources realize that, we could probably save them money if we, really legitimately knew what it was we were working on with some of these kids, that, maybe they'd be more on board with it as well.
I have most parents, when I recommend it, especially I'm also certified as a CLC, they're really afraid of the tube hurting their infant. And I'm like, no, it's this smaller than your pinky finger. It's just like them picking their nose. That's kind of how I describe it. And
The pediatric scopes are probably smaller than about the size of a strand of spaghetti now.
You just made my nose itch and run as soon as you said that. I'm totally serious.
Well, don't be jamming any spaghetti up there. But
no, what you don't know is I had really bad morning sickness with spaghetti noodles, so I cannot do spaghetti. So, like, fun fact. Okay, but folks, bear in mind that different states have different regulations about home-based fees. So make sure that we're huge proponents of this. Please do this. Please start engaging this in your practice. However, make sure that your state licensure allows you to do it in home health. I know a lot more can do it attached to an otolaryngologist ENT office, or attached to a hospital. Like if you're in a facility attached to a hospital, but before you go out, buy a machine and run a spaghetti noodle down a kid's nose, make sure you're legally allowed.
Yeah, absolutely. And, I'm talking all theoretical here. Make sure that you're, up to date on ASHA's recommendations about, your body of knowledge. As a state board member, I'm telling people to be aware of what's in their rules and regulations from a state board level. You will have everything from states that completely outline what you can and can't do, to states that do not say anything in the way it's worded. So there's that whole spectrum. And then, of course, you have to know about payer source. What does your payer source allow or not allow, depending on who you're sending a bill to. So, I'm just kind of talking theory here. I don't know if anybody's even doing pediatric fees in home health anywhere in the nation. But it is available, intra-office for sure.
Yep. Okay. So you talked about fees in the nursing environment, but I remember when I first started hearing about fees, and I had, Vince, 2 ASHAs ago, I had this amazing opportunity to see Dr. Bonnie Martin Harris, who I really want to grow up and be, but I feel like I'm going to turn into like Mary Poppins with a wine problem instead, but like Dr. Bonnie Martin Harris. And I got to see Susan Langmore. And I got to see, oh, bless it, I can't remember her name, a brilliant speech pathologist from MUSC. And she was focused on manometry entering our world. Susan Langmore was talking about fees, and Dr. Bonnie Martin Harris was talking about modifieds. And in that, it was one of their master classes, right? Like I paid all the extra money to go see it. And in that 2-hour long talk, what they did was they compared the same swallow, like one patient going through all 3 different assessments, and how amazing it was. And the whole debate was, it's not, is one better than the other? They're all great. They just tell you different info. So like the whole is modified's the gold standard.
And
Yeah.
you brought up a fantastic point that we have so got to stop talking about in versus language, because it's not it's not one against the other. It is, what clinical question are you trying to answer? And that clinical question can, maybe it can be answered by either or maybe you need a combination of those tests to get the appropriate clinical answer. And that's the way we need to be thinking. And then we may also be referring, we're probably also going to be referring to, in your case, pediatric GI a lot of times.
Yes. And ENT, aerodigestive tract issues run rampant. EOE, milk protein allergies, celiac disease run rampant. And what we're seeing a lot of is, when you're talking about GI, esophageal stage dysphagia masquerading as an oral stage dysphagia. So insert everybody thinking they need to bust out a chewy tube. It's going to fix all the things. And it won't, people. It won't. Leave them alone, put them in a drawer, let them collect dust. But it's actually a breakdown downstream that's resulting in something on the front end.
Comparing it to the population I used to work with, I saw a lot of patients with gastroparesis. Guess what? Gastroparesis, if you don't know what it is you're treating, looks a whole lot like oropharyngeal dysphagia.
Does it really?
Oh, sure. When you have limited or no movement in your esophagus and your stomach, and gastric emptying, and it just fills up. It's one big long tube. What's going on at one end is going to affect the other end. Whenever I have students or whenever I have CFs, one of my examples is I hold up a hose and I fill it full of water and I crink the end. And it doesn't matter where that crink is, you're always going to have problems at the top. So you look at pressure issues.
Absolutely beautiful.
Yeah, you look at, one of my professors in school, Dr. Robert Johnston, said, swallowing is just one big long tube, and we've got to look at the whole tube. We can't just look at head and neck. It's got to be a bigger, more holistic picture of the patient. And it's diagnosis dependent. I mean, we've got to understand what those primary diagnoses are going to mean for patients. So in your case, if you're seeing a kid with, say, Down syndrome as compared to a child with some sort of craniofacial abnormality, you're going to expect a completely different kind of swallow problem. So you've got that's where our bedside skills are so important. And I think people often misinterpret what I'm saying, that what we know and do at bedside doesn't matter. That is not in any way what I'm saying. You have to know contextually, how does it apply to the patient that you're seeing at the time. And something that I found really interesting, like you, one of my most eye-opening, oh gosh, I think about the course and it gives me chills. It was so great, but it was a debate between Dr. Stephen Leader, who has unfortunately passed away at this point. Dr. Stephen Leader, Dr. James Coyle, and I think Dr. McCullough. I believe I'm correct about that. But anyway, whoever it was, they were talking about, do we even need to do bedside swallowing evals? And what I took away from that debate, from that hour-long debate, was if you don't know the context of what you're hearing, seeing, being described by the patient, that bedside swallowing eval doesn't do you any good. It's when you do that instrumental that you then know the context of what all those sound, like you were talking about sounds, pops, clicks, whatever. They may mean something, and you can only put them in context once you visualize them with the appropriate test. The McNeil Dysphagia Therapy Program that is so popular now with Dr. Crary and Dr. Carnaby, one of the things I took away from them was once you do a modified, once you do a FEES, then those noises and belches and burps and whatever that you may see at bedside, then they have context. Then you can use them as clinical indicators. So, it's not that our clinical skills aren't important. It's just in which order we're using them a lot of times.
So everybody that's listening, take your information from bedside. And I get it. You're in a home. You're not there at a nursing home or a hospital doing a bedside swallow eval. You're with a mom holding up her medically fragile child in her arms because they don't have proper seating in the home because adaptive equipment or durable medical equipment hasn't been referred to yet, or they don't have anybody nearby. Take what you're seeing during that eval, convey it to the person that's doing the instrumental, and then y'all have the crucial conversation of, okay, this is what I'm seeing. This is what we saw in instrumental. Now let's create a functional plan of care to move forward to help that little one best meet their intake goals. And again, run that by RD because I always defer to RD. Dun, dun, dun. Okay. So yes, FEES is as good a test as modifieds, but tell us why. Can you, tell us about the FEES in particular? What can we see with it? I want the meat and potatoes, not really meat. I'm a vegetarian, but
So, again, going back to the, what's the gold standard conversation. The way I explain this to people is depending on what clinical question you have, that's going to be your most appropriate test. So FEES gives you a view that is complementary to, but different than a modified barium swallow study, where you're looking, at a lateral section, and you're kind of viewing this silhouette of function. Again, modifieds are a great test if you're wanting to really examine closely, like how esophageal function is impacting oral pharyngeal function. That's your test. The FEES is more of a top-down, kind of like you're viewing the topography of the swallow. And it gives you a in-color live view of whatever your dysfunction may be. People always point out, but you have that whiteout period. When your epiglottis covers everything and that swallow occurs. So while technically that is true, whiteout occurs, I think it's 0.38 milliseconds. That's how long it is. 38 milliseconds of
super brief.
Yeah. So the literature tells us that FEES is actually able to determine, aspiration and why we're aspirating at the same or slightly higher rate than a modified. Dr. Lori Burkhead said something to me one time that I always tell people. She said, if I had to choose between a modified and a FEES, that I would choose a FEES 51% of the time and a modified 49% of the time. And and in talking to her about this and in me developing my own clinical approach, the thing about a FEES is it's so easy to do with a patient. You don't have to move the patient. They can be in bed. You bring the equipment to them. Some of these small portable systems are just so easy to set up. You can go in, be in and out, done with your test, 15 minutes. You haven't
You can
interrupted.
do it on a breastfeeding baby in
Yes,
side-lying position. Sorry. Yes.
absolutely.
Yes. Sorry.
Absolutely.
Just trying to get an infant into
Yeah.
the position in a modified chair. You can't do that. That's not their normal state. Yeah.
And where you're looking at exposing an 80-year-old to radiation is one thing. Exposing a brand new infant to radiation is a totally another thing. Because you carry the effects of whatever you're exposed to radiation wise forever. It's cumulative for the rest of your life. Yeah. So, you may have to do a modified that may be clinically appropriate for that infant or young child. But, with the FEES, you can see if you even need to progress to that next step. For me, from a speech pathology perspective, it makes us so much more independent and knowledgeable practitioners. We're not dependent on a radiologist standing there next to us to do the exam. It is our test. It is our body of knowledge. And, despite what, like you were talking about, parents being concerned about it hurting their child, it really doesn't. I haven't done a lot of pediatric, I haven't done any pediatric FEES, but I've done between 3,500 and 4,000 adults. And
Oh my Lord. That's a lot of noses, Vince.
maybe one out of 300 are like, nope, I don't like that. You can't, we're not going to do that. Most people tolerate it just fine.
Also, for the pediatrics, if it is uncomfortable, when they go to nurse, when they go to latch back on, whether it be at bottle or breast, they have an endorphin release. And so it offsets any fear or that fight or flight fear because they go right back into that nutritive suck pattern. And so there's a whole body of evidence, especially
you taught me something
the breastfeeding literature. Oh yeah, it's an endorphin release for both the mother and the infant, and it actually it's just beautiful. Yeah, that was. Yeah. I breastfed both of our children, and the bonding experience, and it helped with my postpartum. So, which is
very cool,
next level insanity. So,
yeah. I have one story about FEES in pediatrics, and that was I had a former CF of mine contacted me, and she said, I have been, a friend of mine from college has reached out. She's now an RN. She understands that SLPs work with swallowing disorders, and she has a new baby that will not latch, that is losing weight. The pediatrician kind of keeps brushing it off like it'll get better. And anyway, she's kind of freaking out. And I said, I really don't know, if the pediatrician doesn't know what to do, I certainly don't. But I would think that, would be to get them in with somewhere that did a feeding, swallowing pediatric clinic, just like we would with adults. And I said, let me call around and find somewhere. So I won't name any names or anything. I'm not here to bust on people, but found them a clinic in North Florida, and they took the baby there. And about a week later, I thought I would reach back out to my to my ex-CF and see how things were going. And she said, well, it's really interesting. I was about to call you and see if you had any further recommendations. They've been going for a week. It's very expensive and nothing seems to be changing. And I'm like, she's like, what do you mean it's very expensive? And she said, well, their insurance doesn't cover it. It's $250 a session, and they keep going for quote unquote therapy. But there's no change in the baby. And I said, well, what did their swallow study say? Have they had a modified or a fees? And she said, to my knowledge, they have not. And I said, well, look, I said, again, I don't work with kids, but I said, I think we really need to find them somewhere that, we can refer to get them a fees or a modified. So we scoured the South Georgia and North Florida areas trying to find a clinician that could do the appropriate testing. We called like every hospital, could not find anybody. We finally ended up sending the kid, I think, to a pediatric ENT who wasn't necessarily familiar with doing the fees protocol, but did diagnose the baby with floppy larynx syndrome or laryngomalacia. So, I mean, this kid was literally about to die, had been in therapy for 2 weeks with an outrageous bill, and simply doing a diagnostic test would have given everybody all the information they needed to treat the kid. So they used spoon feeding. Baby started spoon feeding and completely reversed course, started gaining weight. I think they did have to end up having some sort of surgery to kind of reinforce
supraglotoplasty.
Yeah. So, but my thinking is, how many people do endless amounts of therapy that they don't need, or inappropriate therapy that they don't need, because you've never got the appropriate diagnosis has never been found. And that's just not an SLP issue. I'm not blaming SLPs. That is a team issue where, you don't have doctors that are informed, you don't have people that are educated to do the procedure, and then out in the field, you're not aware of why it's important to do it and not just feed somebody.
Okay, so that's where we all practice in a silo. That's the story that I hear all the time in our world, where people either say it's a pediatric feeding aversion, it's a behavior, and like doctors crack up, oh, they just don't want to eat because they have autism and they're just a picky eater. It's all behaviors. I get on my end, oh, they just have a rattly breathing. They'll be fine, blah, blah, blah. But laryngomalacia is no joke. Like, that can cause obstructive sleep apnea, that can cause, which causes oxygen deprivation to the brain. I mean, like a whole host of issues. And we hear that all the time. Okay. Squirrel, that's like a whole soapbox. I've actually done an entire episode just on laryngomalacia. But we're talking about how when you actually do the fees, how it tells you why a patient's aspirating and if they aspirate, but the why, the physiology. I need that.
Sure. So you can get there are certain things that you can't, I'm very honest about this. Just like a modified, there are certain things that you can't figure out with the fees. But, point of swallow trigger, does the patient have UES dysfunction, base of tongue issues? All of those things are very detectable, with fees. When you're an experienced provider, you can easily tell if it is a pharyngeal squeeze issue versus pharyngoesophageal segment dysfunction that's causing backup. You certainly can tell if they're aspirating or not. That's not a problem. And you can then extrapolate, for the most part, why they are aspirating. Langmore said something really interesting in one of her papers, and she said a normal swallow on fees is super boring. You look at it and you don't think you're seeing anything. It's when there's dysfunction that fees shines. So you're able to see, what anatomy and physiology
Shine.
looks
I
like.
like that.
Yeah, you're able to see, from my perspective, one of the great things that fees is so useful for is like when patients have swallowing issues post extubation, you can see if they have a misarticulated arytenoid or a broken arytenoid. You can see if there is paralysis of vocal fold function. You can see where it's frozen. Um, is it midline, or both folds open? Do you just have one that's working? You can detect all that stuff, and I've really, I think we talked about this a little bit earlier in the podcast, but I really think of fees as a study of upper airway function. Okay, how how is that upper airway functioning in relation to um, swallowing? Do you have someone? I've just got endless stories with fees, but I, I think back to a gentleman that had been on honey thick liquids for years because he was quote unquote aspirating. Well, he was aspirating, but it was only once you did the fees that you realized he was aspirating on what was coming back up, not on what was going down. So, this.
What did he have? Did he have a Zinkers? Why?
So, he had, when we're diagnosing those issues, we don't really make a medical diagnosis. You know, all I could what I could see was this guy had retrograde movement of the bolus. So he would swallow, and after he would drink a little bit, then it would just kind of creep back up from where the upper esophageal junction is, and you would see it just spill over into his airway. And it had happened to him for so long that he would just have massive amounts of aspiration as a result of it. He never coughed. It didn't bother him anymore. He was completely desensitized. Um, so, those are issues that happen with kids and infants. You have retrograde movement of the bolus. You have esophageal dysfunction, and so then you know where to appropriately send your patient for treatment. Um, another one that comes to mind was uh, a lot of nursing facilities now incorporate nurse practitioners or PAs that work for managed care companies. And part of their job is to be on site and to try to cut down on unnecessary care costs. So apparently, there was a patient in the building that kept getting referred to speech, and the nurse practitioner, she would keep intercepting the request for screen and say, "Oh no, this is reflux. There's nothing speech can do about this. I'm just going to up their medicine." And this went on for weeks. So we're into like month 2 of this increasing cough during meals for this little demented lady, and the DON of the building finally said, "Look, we're used to having speech involved in these type of patients, and whatever you're doing is not working. Can we please get speech involved?" So, a really good clinician that I work with, you know, went and did, or that I did work with in the past, went to the patient's room, did her bedside, and said, "Something's wrong with this patient that I can't see at bedside." So then she requested a fees. You know, in the nurse practitioner's mind, this was just unnecessary money that was going to be spent. So then we had to convince her why we were going to do the fees, what we were looking for. So I kid you not, when we scoped this lady, she had about a tennis ball sized tumor that had grown within her throat. You couldn't see this at
Oh
bed.
my God.
Oh yeah, you couldn't see this at bedside. But But it was super clear as soon as you feased her and you saw the changes in anatomy. And it also taught me something else about nurse practitioners, doctors, PAs. They're not really familiar with that view. And the nurse practitioner had no idea what she was looking at. That was
But that's what they go through sorry, I'll behave myself.
right. But that's what we should know as SLPs. We should be
Yes.
the kings and queens of upper airway gastric dysfunction. And so we were then able to say, look, you can give her all the reflux medicine you want, but she's got a tennis ball sized tumor in her throat that every time she swallows, her epiglottis hits it and she coughs, and then she stops eating. So that's your issue. So, you can't know until you look. There's I think ASHA's guidelines about whether or not you should get an instrumental is you have to consider if the instrumental is going to make a difference in your plan of care or how you're treating the patient. And quite honestly, I can't think of a whole lot of circumstances unless you just have somebody that is truly end stage, truly terminal, truly somebody that just can't tolerate instrumental testing, where that is true. Most 99.9% of all your patients are going to benefit from testing. One of my big interest areas now is I'm kind of orbiting dysphagia as I'm getting more and more into chronic cough syndrome, irritable larynx, which is an issue in pediatrics as well, particularly in adolescent. Not that it doesn't affect boys, but apparently there's a prevalence of this in adolescent girls that are active in sports, and you have to strobe and assess vocal fold function to make the appropriate diagnosis. So, that's my soapbox on it. I think as a profession, I'm real impressed with, how we have moved more towards instrumentation being expected and more available over the past 10 years, but we still got a long way to go. And I hope that 10 years from now that fees is so cheap and available that it's just something that we don't even think about anymore, that we just get them, that we just have them available. I think we're moving in that direction. It used to be a system, it used to be if you had instrumentation done, you were in an ENT office and you were using equipment that cost $75,000, $100,000. You can get a system now for 15 to 20. So it's going to keep decreasing in cost, I feel like.
Okay, so for the peds world, y'all, when I have sent pediatric patients, I do not personally locally have anyone at this moment in time that's doing fees. I've heard that it's coming through the grapevine, but I don't have that as an option in my immediate area. Slightly farther south, yes. But I've had plenty of patients go to an amazing ENT friend of mine, and when they actually go in either in office, they've caught things in office, or when they go, bless it, I've had a couple patients and I'm like, we have a failure to thrive diagnosis and we're not gaining any weight and all these things are happening. Can you please do a scope? They go into the ENT office. The ENT takes one look at them and is like, we're going to go ahead and schedule you presumptively for the OR because they can see, right? And they'll go in. I mean, they can, they do their bedside, but they also know that they need to do a scope. They have caught laryngeal clefts with scopes, especially more severe clefts. The bronchoscopy is like best practice for catching like the intense level 1, level 2 ones. But I mean, if it's a wide open, very obvious laryngeal cleft, you're going to see it. We've had intubation damage, webs,
polyps, nodules prevalent after chronic misuse and abuse. And when those vocal folds can't meet at midline because there's an obstruction or a tethering issue, like a laryngeal web from trauma due to stat intubation, especially folks with your little ones that have seizures. I mean, if they're having a severe, say they're having a grand mal and they've been at it for several minutes, when they actually get in the ambulance, I mean, they're hitting rocky, bumpy roads when they're trying to handle the patient on a very rural route to the closest hospital. I mean, I know there's a lot of people that listen that a nearby hospital might be 45 minutes away. And so all of these things can happen in the attempt to save and resuscitate the tiny human. And our congenital abnormalities, Vince, is it, I'm going to butcher the word, papilloma from the HPV virus. Is that how we say that word, papilloma? They may not know the extent or severity of it. Warts, there's a reason that mothers are tested for sexually transmitted diseases during their pregnancy, because some of those can pass over, and that can actually impact the laryngeal vestibule. And if you have a kiddo that, I mean, the mother may not feel comfortable sharing that information with you during your PMH. The mother may be a legal guardian, or the child may be in foster care, and they may not know that information. And some of this is visible externally, but you need to have instrumental evaluation. Those are the kind of factors that, for me, man, I wish we had fees here. Personally, I couldn't do it. I have a killer gag reflex. So me trying to do it on somebody else, like I gag trying to brush my own kid's teeth. So like, this is not my thing that I want to do, but I need somebody who's got a stronger gag reflex than me to like do this to help my patients. So like, full disclosure, but I appreciate those that can. So thank you, Vince. I'll gladly sit and be on the receiving end of a scope, but I couldn't do it personally. Yeah, I remember I had to do it one time as a student. My supervisor asked me to hold the scope so she could rearrange something, and I almost threw up on the little old man that had a stroke. And she was like, "See, you can let go now." I was like, I'm sorry. But like, oh man, I still don't know how I graduated grad school. Okay. All right. So we have like 3 minutes left, but why do you feel that fees is a great option for pediatrics in your last 2 to 3 minutes?
You know, circling back to kind of the whole theme of this talk, to me, it you know, again, it's not, is fees better than a modified, but it's so much more accessible most of the time. You know, I always tell people it's really hard to carry a radiology suite on your back, but you know, we're to the point now to where we can tote a fee system, you know, in our hands. So there's more and more adult um, portable fees businesses that are springing up, um, and I feel like there's just this great open space for someone to, you know, partner with a pediatric ENT or a pediatric, even a pediatric pulmonologist maybe, or a pediatric gastroenterologist, and start doing these scopes so that, gosh, just to put it simply, so that we know what it is we're doing, so that we are making appropriate diagnoses, you know, so we're not wasting, you know, Medicaid or Medicare dollars or private, private funds, whatever. Um, I just feel like there are really no downsides to it. It's all upside. It's just this shift. Again, like you say, it's something that's emerging and becoming talked about more and more and more in pediatrics, but it's just a shift that I feel like once it starts happening, it's just going to be like a tidal wave, and just kind of become the standard of care. But you know, look for, try to reach out, try to look in your area, try to find, a pediatric ENT or some, whatever the specialty may be that is using endoscopy, nasoendoscopy to make diagnoses. I'm assuming that pediatric GIs are also using the nasoendoscope to examine the esophagus, which is becoming more and more common in adults. So you may very well find a professional that is doing that. So you get a lot of bang for your buck. They can check out the airway and they can keep on going and see if that GI tract's working like it should. It's just a lot of options once you start working and once you realize why it's best practices to do these things. I hope that answered your question.
It does. And I appreciate it because we need this, because I can't just rely on until we have x-ray vision, which I kind of feel like that could happen before the end of my lifetime, maybe not the end of my professional career. I was a huge fan of Inspector Gadget growing up, so I got high hopes. All right, so Vince, if folks want to learn more from you, or if they want to speak to you about how they can sweet talk you into coming to their facility or state convention, because y'all, Vince packs a room, I can attest to that. How can they reach you?
I have an open Facebook page. They are more than welcome to contact me over Facebook. I'm also available on LinkedIn. Feel free to find Edgar Vincent Clark on LinkedIn. I actually go by Vince, but Edgar's what's on the license, so that's kind of how I present myself professionally. And then my email address is Edgar V. Clark. That's all lowercase with no spaces at gmail.com. You're certainly welcome to reach out to me that way.
And can I let the cats out of the bag that you're coming back and doing another one on leadership? Because
Sure.
That is something that's very near. Yes. So y'all, Vince is coming. Vince is a past president of Georgia. And I make a joke about it being called GASHA, which sounds like a wound, which is one step better than skisha, which sounds like a sneeze fart. And so this is near and dear to his heart too. So he's going to come back and we're going to talk about leadership, because those of us that have old gray hairs need to make sure that we're building up the ranks to carry our profession forward.
It's a passion topic of mine.
Yes, likewise. Okay, so everyone that's listening, friendly reminder, happy Cinco de Mayo. We appreciate you. Vince, real quick, what is your favorite margarita? That was a big sigh. I had to think.
I love a good margarita. I guess just the traditional one. I've never ordered. Are there other kinds of margaritas out there?
See, I get the honeydew melon one because I can't drink tequila. So it makes me think I'm at one with the universe. This is bad for everybody. So honeydew vodka melon margarita, it is not really a margarita, but at least that's what Cantina is.
I typically like a good, just what is it, the top shelf tequila margarita salt, just the traditional.
That's yes, I could.
But I do love a good margarita.
Yeah, but I'll let you, when we sync up next time, you can order that and I'll order the vodka version. Go team. Right. All right, hang on. Let me switch us over to questions really quick. Hold on one second. Feeding Matters guides system-wide changes by uniting caregivers, professionals, and community partners under the Pediatric Feeding Disorder Alliance. So what is this alliance? The Alliance is an open access collaborative community focused on achieving strategic goals within 3 focus areas: education, advocacy, and research. So who is the Alliance? It's you. The Alliance is open to any person passionate about improving care for children with a pediatric feeding disorder. To date, 187 professionals, caregivers, and partners have joined the Alliance. You can join today by visiting the Feeding Matters website at www.feedingmatters.org. Click on PFD Alliance tab and sign up today. Change is possible when we work together.
That's a wrap, folks. Once again, thank you for listening to First Bite, fed, fun, and functional. I'm your humble but yet sassy host, Michelle Dawson, the All Things Peds SLP. This podcast is part of a course offered for continuing education through speechtherapypd.com. Please check out the website if you'd like to learn more about CEU opportunities for this episode, as well as the ones that are archived. And, as always, remember, feed your mind, feed your soul, be kind, and feed those babies.